accomplished scientist and recent recipient of the Shanti Sirupatnar Award. So I would like to welcome the distinguished speaker, Dr. Jimon P, to this particular lecture. Despite his busy schedule, he has been very kind enough to accommodate our request. Welcome, Dr. Jimon.
Thank you.
So next, I would like to welcome the members of IEEE MBS Kerala chapter and members of IEEE Kerala section, and all my colleagues as well as others who have assembled here. So let me now introduce the speaker here. Dr. Jimon has demonstrated exemplary research leadership in advancing cardiovascular disease science by focusing on its prevention and control in India. His research contributions, especially in developing new models of primary care for management of cardiovascular risk in community, worksite settings, and in high-risk families is commendable. He has collaborated in the past with prominent researchers in this field, both from India and abroad. The number of high-impact research publications emanating from his research projects speaks for the volume and quality of his work. He has gained expertise in different study designs to advance science that is focused on cardiovascular epidemiology. The number and size of the research grants that he holds currently speaks of his research leadership skills. Dr. Jimon started his independent research career immediately after obtaining PhD in medical cardiology from one of the premier medical schools in United Kingdom. His PhD was supported by a doctoral fellowship from the Wellcome Trust. He was graduated from the Institute of Cardiovascular and Medical Sciences, University of Glasgow in 2012, and studied novel predictors of mortality in individuals with hypertension. Immediately after his PhD, he was awarded a career development fellowship from the Wellcome Trust. This fellowship was a stepping stone for him to secure another prestigious and highly competitive intermediate level fellowship from the Wellcome Trust DBT India Alliance. As part of this fellowship, he developed a novel model for cardiovascular risk reduction in individuals with a family history of premature coronary heart disease. This work has been highlighted in various reports of the India Alliance and Research Outreach magazine. Subsequently, he has been awarded the prestigious Senior Fellowship from DBT Wellcome Trust India Alliance 2021 to 2026 to develop a novel model for management of heart failure with M-Health support. The continuing support from Wellcome Trust for his career and research development is a testimony to his research credentials, hard work, and dedication. Dr. Jimon is currently focusing on improving the quality of care in primary care settings for patients with multi-morbidity. Currently, he is holding several major research grants from Medical Research Council UK, NHMRC Australia, NHLBI USA, World Diabetes Foundation, and Indian Council of Medical Research. He has more than 130 publications to his credit and listed in PubMed. His current H-index is over 70, and it shows that he is far ahead of his peers in his age group. Additionally, he has established collaborations with multiple global institutions of prominence as evidenced by joint publications in high-impact medical and epidemiology journals. He also held honorary appointments in University of Birmingham and University of Glasgow, UK. He is also an associate editor of BMC Medicine and Annals of Family Medicine. Most recently, he has been awarded the prestigious Shanti Sirupatnar Award for the year 2021. So, once again, we welcome Dr. Jimon for accepting this invitation to the lecture, as well as delivering your lecture to the audience assembled here. Yeah, thank you for listening, and over to you, Dr. Jimon.
Thank you very much. Thank you very much for your kind words and all that glorified statements. I also, it's a pleasure to meet you all. Unfortunately, because of the COVID reason, there is no way I can physically meet you, but at least through the virtual medium we can interact. And thank you, IEEE, for having me in this important session. So today I'll be talking about cardiovascular disease. Most of you probably are familiar about cardiovascular disease, but I will take you through the I'll take you through the cardiovascular disease burden issues and how we can manage and address cardiovascular disease in our setups, especially in the Indian settings. Let me share the screen and can you see my screen?
Yes, yes. Thank you.
Thank you. So today I'll be largely focusing on cardiovascular disease burden and its priorities for prevention in the Indian settings. Before I start the session, let me introduce my mentors, Professor Srinath Reddy and Professor D. Prabhakaran. These are the two people, the reason why I am in preventive cardiology. My conversion to preventive cardiology started way back in 2002 when I started interacting with Professor Reddy, who was then at the Professor of Cardiology at All India Institute of Medical Sciences. And a year later, I met Professor Prabhakaran as well in the same institute while I was working for a partnership council of WHO, which was headed by Professor Srinath Reddy and also by Dr. Prabhakaran. So since then, I've been focusing on cardiovascular diseases, mostly in the Indian settings or in the low and middle income country settings. So let me start with the burden statements, but unfortunately with an obituary note. The obituary note is a very serious obituary note of cardiovascular disease. It is about 18.6 million cardiovascular deaths annually. That's happening globally. And that's about 33% of all the mortality. And that's one of the reasons why I'm talking about cardiovascular disease today. And of these 18.6 million cardiovascular deaths, 9.1 million deaths, 9.6 million are in males, and 8.9 or close to 9 million are in women. There is a general perception or a myth that that's circulating in our society that it affects cardiovascular disease affects mostly men. That is not correct. Now, if you come to if you look at the mortality statistics, it's almost the same: 9.6 versus 9 million deaths in men and women. And among the cardiovascular disease, of these 18.6 million cardiovascular deaths, 9.1 million are due to coronary artery disease, or in our local term, we call it as heart attacks. And 6.6 million deaths are due to cerebrovascular disease. In local terms, we call it as stroke or brain stroke. So together, these two conditions together covers almost 90% of the cardiovascular death. And what is more important here is that 40% of these deaths occur in people less than the age of 70 years. And of them, those who are occurring below the 70 years, 90% of them occur in low and middle income country region. So it is not only an issue for developed high income countries, it is definitely an issue for low and middle income countries like India as well. So now let's focus on India. What's happening in India? The CVD statistics for India, the latest statistics says that in India annually we have at the moment 2.6 million deaths. So we were talking about COVID. COVID as a big issue, threatening the economic development, threatening whatever we have been doing in the past 10 years, 2 decades. But look at the mortality statistics. I'm not saying that COVID is not important. We have about 500,000 deaths from COVID so far. But look at the annual deaths from cardiovascular disease. It's 2.6 million deaths in India. It is far higher than the COVID epidemic, the impact of COVID had. So 28% of all deaths in India is also due to cardiovascular disease if you convert that into proportion of all the deaths. So there are other ways of expressing the burden of disease other than the death, and one of them is years lived with disability or YLD. So if you look at YLD, it contributes around 3.4 million years lived with disability in Indian settings, and also 65 million disability adjusted life years lost due to cardiovascular disease condition alone. On your right hand side, what you're seeing is the lead table for various disease conditions that contributes to death in India. in 1990 versus 2019. What you're seeing here is that the trend from 1990 to 2019 with regard to various conditions attributable to death. So what you are seeing is that infectious disease conditions, maternal and child health conditions, nutritional disorders are on the decline in the last 2-3 decades. And while you compare it to the non-communicable diseases like cardiovascular disease conditions, diabetes and chronic respiratory diseases, it is on the rise. And we call it as epidemiological transition. This is not a new concept. The epidemiological transition has been happening across the world. But whatever that has been happened over a 150-year period in the developed countries, it is happening over a shorter period of 2 to 3 decades time in the Indian settings. So that is the importance of epidemiological transition in India. Now let's look at what are the main conditions that's driving the epidemiological transitions. Definitely what you see on the red color bars, it's the negative side of it. The infectious disease conditions and maternal and child health conditions, they are decreasing. There is up to 30 to 40% decline in these conditions in terms of contribution to death in the past 2 to 3 decades. While we compare it with cardiovascular disease conditions like ischemic heart diseases or cerebrovascular diseases, it is on the positive side. So definitely there is an increase of cardiovascular disease conditions in India. And it is not only that, if you look at the projected mortality, I'm really sorry that all these slides are related to this obituary burden, but this is very important to highlight that. From 2004 to 2020, 2030, in around 2004, we had less than 1.5 million deaths from cardiovascular disease condition. And today, as of now, I speak, we have an annual death number of events of 2.6 million. And this is going to increase to up to 4 million in 2030. So that's the impact of cardiovascular disease conditions. And let's now look at compare with India versus some other countries, high income regions, United States of America, and within India, some of the states, some of the regions like Mumbai, Kerala, and Andhra Pradesh. Even if you look at an age standardized mortality rate, when you standardize it for the population structure, the Indian age standardized mortality rate from cardiovascular disease condition far exceeds than that of United States of America or the global average or the high income country average. And within India, if you look at it, Mumbai, Kerala, Andhra Pradesh, so there is a substantial contribution from cardiovascular disease, because the age standardized mortality rate is far higher. So what is the implications of it? It's definitely it's increasing the rising challenge of cardiovascular disease. It is threatening the economic development of all these regions. But even within the younger population, even if you look at the most productive years of life from 15 to 59 years age group, the conditions, there is a significant increase from 2008 to 2013 in terms of the projected increase. So definitely these conditions are going to remain here for some more time. So if you compare with some countries like India, China, Russia, United States of America, and if you only focus within the 35 to 64 years, we call it as the productive life years. And if you look at the years of life lost within this productive life period, so the Indian burden is going to double from 2000 to 2030. So significant increase in cardiovascular disease mortality. So why is it happening? One reason could be that the disease severity in the Indian settings is very high. As you see in this slide, with the green bars are for high income countries, the gray bars are for middle income countries, and the orange ones are for low income countries. Major cardiovascular diseases, the incidence is higher in the low income country regions. Here, the low income country in this particular study is completely represented by India. So the non-major cardiovascular disease, we don't see much differences. If you look at the total cardiovascular diseases, the event rates are almost the same. But when it comes to the fatal cardiovascular disease, that the events that kills, now you see a trend in the low income country regions. It is the rates far exceeds as compared to the high income country regions. why the disease severity is very high, and also they are not getting the appropriate treatment to manage these conditions. And one of the major risk factors that drives the epidemic of cardiovascular disease in the Indian settings or the global era is hypertension. So hypertension is a global epidemic. It is a pandemic. The term pandemic may be familiar to you because of the COVID epidemic, but even before the COVID epidemic struck the world, hypertension, cardiovascular disease has already established as a pandemic because it covers all the regions of the world. And if you look at the hypertension, the contribution of hypertension to the global mortality, it is around mortality across different regions. In India, it contributes around 22.5% mortality. In United States of America, it contributes to 17% of the mortality. So wherever you look at it, any part of the world, it contributes a significant burden in terms of the number of deaths. So why do we need to worry about hypertension? Why do we need to develop a roadmap to address hypertension? Is that at the moment there are about 1 billion people with hypertension globally. That is about one in 4 adults. And the problem here is that only fewer than 1 in 5 have their hypertension under control. That's a major reason. And that is one of the reasons why hypertension is now a major #1 risk factor for death globally. When it comes to the Indian settings, what happens with hypertension is that only 20 to 25% of people with hypertension are aware about their blood pressure status. The study that we did from Srijitra as part of the Kerala statewide efforts to estimate the burden of hypertension.
I think there is a minor network disruption. This Walton, I think he'll be back soon.
Can you hear me, sir? Can you hear me? Can you hear me?
Yes, we can hear you.
Yeah, we can hear you. We can hear you.
All right. So in terms of the hypertension, the study that we did in Kerala, see only 15%, that is about 1 of 6 people with hypertension.
Are you there?
Yes, sir. Can you hear me? I'm sorry, I think there is some.
Yeah, okay. Welcome back. Yeah. Dr. Jivan, can you hear me?
Yes, yes, sir.
Yeah, there was a very brief disruption. We can continue from where you left off. Yeah, thank you.
So the study that we did in Kerala for hypertension, it's only about 15% of the people, 1 of 6 people are aware about their blood pressure status or their hypertension status. And that's one of the reasons why we need to consider hypertension, and we need to devise strategies to address hypertension. When it comes to another risk factor for cardiovascular disease condition, which is diabetes, which is a devastating condition. At the moment, globally, 537 million adults are affected by diabetes, and 643 million, we are expecting that this number will increase to 643 million. And what is important here is that 3 or 4 adult individuals with diabetes live in the low and middle income country region. And India, as all of you know, that we know as the diabetes capital of the world. And most importantly, what is the most important issue here is that almost 1 in 2 are undiagnosed or underdiagnosed. They don't know they have the diabetes. They are living with diabetes, but they don't know that they are living with diabetes. And diabetes together contributes 6.7 million deaths globally on an at an annual rate. And it also affects children and adolescents. It affects 1 of 6 live births because of gestational diabetes mellitus. And we are also expecting that now there are a lot of people who are at risk of developing diabetes. And if you actually look at the studies that we conducted in India, clearly shows that the progression from pre-diabetes stage to the diabetes stage, or the high risk for development of diabetes stage to the full-blown diabetes stage, is much faster in Indians as compared to their Caucasian counterparts. So what propels actually the cardiovascular disease epidemic? If you actually look at Rudolf Virchow way back in, a very famous physician, anthropologist, he said that, do we not always find the disease of the populace traceable to the defects in the society? And I quote him again, if disease is an expression of individual life under unfavorable circumstances, then epidemics must be indicative of mass disturbances. So it is something happening in the society. It is something happening at the population level. Some issues happening at the population level that's propelling the cardiovascular disease epidemic. And let's look at the determinants of cardiovascular disease epidemic.
Yeah, looks like another small network disruption. So wait for Dr. Jimon to come back. Thank you for waiting.
So can you hear me, sir? I can hear you. It looks like the disruption is at your end, sir.
Yeah, we can hear you, Mr. Jimon. Yeah.
Okay, thank you. So the determinants of cardiovascular disease epidemic, one of the main reason is obviously demographic shift or aging of the population. We all die at some point in our time, in our life. And if that is due to cardiovascular disease, we are not really worried about it if it is in the later stage of our life. But if it is in the early stage of our life, we are all worried. Urbanization and industrialization are important determinants of cardiovascular diseases because it has direct impacts on the living habits. How we behave, how we travel, everything is related to urbanization and industrialization. Globalization has an impact because the marketing strategy, the food marketing strategies, various companies adopt has a direct impact on cardiovascular disease epidemic because it determines what we eat and what we consume. Educational level has importance. Culture, the beliefs that we have, various beliefs with regard to dietary practices, various beliefs with regard to other practices like tobacco, alcohol, they are all related. Poverty, because the poverty, how is poverty is related to cardiovascular disease epidemic because it has direct implication in terms of access to health. And in addition to that, the healthier options probably would not be affordable to the poor in our country. So poverty would also have direct implications in terms of cardiovascular disease. The built environment where we live, how it is structured, they may act as barriers, some of them may act as enablers. But ultimately, the vectors that propels the cardiovascular disease epidemic are four of them: tobacco, unhealthy food, alcohol, physical activity. Although all these conditions are determined by the factors that I mentioned above. So how can we develop a strategy, a multi-level strategy to address a multi-level determinants of cardiovascular diseases? And if you look at the global and the national level, we need to think about the global development, how the income is distributed, how it impacts the demand and supply of various of these risk factors or the risk conditions that I just mentioned. And when it comes to the community or family, we need to address the perceptions, the cultural perceptions, the priorities or the socioeconomic priorities set by the family members or the community members, and also in terms of the pathways, the availability of services, access to the services, availability of medicines, access to the medicines, all these are important. And when it comes to the individual level, it is largely the beliefs, behaviors, and biology at the individual level. When I say biology, we call it as the genetics or the genetic makeup. That also has an important impact in terms of determining cardiovascular disease conditions. So now let's look at what are the various risk factors of cardiovascular disease conditions. I already alluded to that. Blood pressure, high blood pressure is the most prominent one, which causes nearly close to 9 million deaths from high blood pressure alone. And if you look at the other important risk factors, smoking and secondhand smoke, diet low in fruits, high BMI or obesity levels, high blood sugar levels, physical inactivity, dietary salt, alcohol use. Many of these dietary variables like high serum cholesterol, diet low in vegetables, diet low in whole grains, diet low in fish and seafood, they're all related to cardiovascular diseases and known as cardiovascular risk factors. So I already alluded to that health system matters, how we address these conditions like myocardial infarction, stroke, heart failure, or major cardiovascular disease conditions. If you look at the way the case fatality rate in high income country versus the low income country, it is much higher in the low income, middle income and low income country as compared to the high income country because of the access related issues, because of the inability of the health system to address these conditions. If you look at the treatment for coronary artery disease and stroke, in this graph, what you see is a study for the findings are from the peer study. The lower middle income country represents here in India. The proportion of people after a heart attack receiving no drug, it is almost 80%. That is unacceptable. And similarly, when it comes to stroke, another devastating cardiovascular disease condition, after a stroke event, the proportion of people receiving no drug is about 50 percentage. So that is also unacceptable. We need to get these essential medicines to the people who actually require this drug. We did a study in Trivandrum, which is called the Trivandrum Heart Failure Registry. We looked at the heart failure people and how they progress over a period of time. Within 90 days, the mortality, the cumulative mortality touches upon 16% to 18%. And when we divided this group into those who received the drugs or the essential medicines, or according to the guideline, we call it as the guideline directed, those who received guideline directed medical therapy, compared to those who did not receive or suboptimally received it, those who did not receive it, the mortality rate was much higher. So definitely the treatment is helping them, but we are not able to reach out to everyone. Only a quarter of all the population, all the eligible people with heart failure receives the guideline directed medical therapy. And when we extend that from 90 days to 1 year, we were getting the same results in the heart failure cohort. And one of the other problem with cardiovascular disease condition is that, as I said, it is devastating. It results in catastrophic health expenditure or distress financing. Catastrophic health expenditure or distress financing are the terms used by health economists to describe the economic impact of the disease at the family level. Distress financing means the family needs to get into selling of their assets, pledging their property, or taking money or a loan from their neighbors or from their friends to manage that acute event in that family. Catastrophic health expenditure means if the family is spending more than 40% of the income after reducing the expenditure for the food and other essential commodities, if they are spending it on health, we call it as catastrophic health spending. So when it comes to India, the proportion of people spending a huge amount of money through distress financing and catastrophic health spending is up to the level of 80%, which is devastating for the family, which would push the family back into poverty again. And that is again a vicious cycle, because poverty will again propels the cardiovascular disease burden, because they would not be able to afford the treatment, they would not be able to access the treatment, they would not be able to opt for healthier alternatives. So what is at the same time happening with regard to recognition of cardiovascular disease as an important condition in low-income countries or in our settings? World Bank, for example, in 1999, produced a report. In that report by Guatin et al., they said that a faster decline in communicable disease would decrease the poor-rich gap in 2020. But under an accelerated rate of overall decline in non-communicable disease, the poor-rich gap would widen. They were thinking that the cardiovascular disease condition or the non-communicable disease condition is only a condition of the rich. And they were saying that if it reduces, it only increases the gap between the rich and poor. But in 2007, now after almost almost a decade, they changed their stand. They said that, in quotes, to what extent do NCDs affect the poor? The answer depends to some extent on the country and the indicator of the NCD burden that is considered. However, in all countries, and by any metric, whether it is the mortality, whether it is the morbidity metrics, cardiovascular disease condition or non-communicable disease conditions account for a large enough share of the disease burden of the poor to merit a serious policy response. So how did they change their stand from 1999 to 2007? That is because of our seminal work that we conducted across India, where we clearly showed the social gradient in cardiovascular diseases. We showed that socioeconomic and health transitions advances within each country, cardiovascular disease conditions and cardiovascular events progressively reverse till the poor become most vulnerable. So we published this work in Proceedings of National Academy of Medical Sciences in 2007, and that made the World Bank to think and change their stand. And what were we saying? That the socioeconomic gradient in terms of the risk factors of cardiovascular disease condition, the first one to reverse is tobacco. We all know that tobacco use is now maximum in the low income group. The second risk factor to start reverse is blood pressure. We have done empty number of studies across vulnerable population, tribal population, slum population, where we demonstrated that blood pressure or high blood pressure, hypertension is an important issue. It is even more among the vulnerable population as compared to the rich population or the economically advantaged population. And next, it comes plasma cholesterol, physical inactivity, and obesity. The last risk factor to reverse is obesity, because it takes much more time to reverse obesity, because physical activity is something that is still people at the low income group are very active, at least in the work domain. So then in terms of the economic growth, there is this the chronic disease conundrum. It's a developmental dilemma that we are facing. What is the dilemma? Economic growth definitely propels good health. It will increase life expectancy. We all know that. But that can also propel the global chronic disease epidemic. Industrialization, urbanization, and globalization, it is part of the economic growth. It is part and parcel of the economic growth that could also propel chronic disease epidemic. But at the moment, because of the epidemic, it is threatening the global economic growth. So the epidemic itself is threatening the global economic growth. So definitely the chronic disease conundrum is a difficult one to handle. So what is that important question that we need to answer? The trillion-dollar question that we need to answer is, how then do we reconcile the economic aspiration of countries like India with protection of cardiovascular health and prevention of chronic diseases? Remember that I'm talking now about cardiovascular health now. So far I've been referring to cardiovascular risk and cardiovascular conditions. Now we need to change that narrative to cardiovascular health, maintaining optimal cardiovascular health. What is it require? This is where the public health meets the sustainable development and social justice. So we should not be merely content with simply cataloging the catastrophe with greater and greater precision. That is not enough for us, nor with a mere coping response or devising a coping response. But what we require, or what it demands, is a corrective response. So what are the ways that we can do that corrective step? What is that corrective step? As you see in the cartoon, most of you know that when we explain very complex situations, there could be some stages where say that, okay, this all of a sudden happened because of some miracle. And there is no magic wand in case of cardiovascular disease conditions where we could erase it from the history. There is no way we can do that. We need to devise some strategies to manage it. What is that comprehensive response to address cardiovascular disease? It requires surveillance for risk factors and disease events. That requires health management information system, and that requires support from engineers and doctors listening to me at the moment. Now we need to develop robust system for health management information system. We need to develop system that take care of the privacy issues of each participants or each individual or each citizens of our country. We need to develop strategies of health promotion, which are health policy interventions or which could be the educational interventions through multi-sectoral coordination. We need to develop clinical care to identify risk factors and manage risk factors, identify disease conditions and manage disease conditions. We need to offer something called the universal health coverage, the essential basket of care to everyone in this country, and make sure that they are getting access to this treatment. And we need to to ensure that we need to invest in the health workforce, we need to invest in the drug availability, we need to invest in technologies that will help us to get these drugs or get these therapies or get these services to everyone. So what is the price of inaction? If we don't do anything, the price of inaction of not addressing cardiovascular disease condition is very severe. The Harvard study with support from the World Economic Forum in 2011, they documented that $47 trillion would be lost due to cardiovascular disease condition and mental health together from 2011 to 2030. So definitely it is impacting the economic growth. So therefore, we need to address this. That is the price of inaction. Now let's look at what is the price of action. What could have been achieved? Now we could reduce or we could minimize 37 million lives lost. We could save them if we act on 6 risk factors of cardiovascular disease conditions. And the gain will be greater if you focus more on risk factors like tobacco. When I say 6 risk factors above the risk factor, the tobacco is also considered, but it is also considered to reduce to the level of 30%. But if you can increase and if you can reduce it by another 20% to make it 50%, the gain will be even greater. And the estimate says that it could be up to the from 37, it would go up to 50 million lives. And gains will be even greater if, in addition to these risk factors, if we can provide the primary and secondary prevention, if we can extend it through the clinical care of all the high-risk persons, through the coverage of essential medicine as part of the universal health coverage package that we have. So what is that magic wand? The magic wand is about having the appropriate policy, engaging the professionals, engaging the patients, and engaging the people, all the citizens. So what are we talking about in terms of policy? Our own estimates based on the modeling studies suggest that simple policy interventions like increasing the task of sugar-sweetened beverages by 20%, it has the potential to reduce obesity levels by 3% and 2% reduction in diabetes. 2% reduction in diabetes at the population level is huge. It will avert many lives, or it will avert mortality from diabetes, several hundreds or several thousands from mortality. 20% tax on palm oil. So what is the problem with the palm oil? It is highly saturated fat, and the palm oil that we get is also not good quality palm oil. So based on the modeling studies, again saying that if you increase the tax of palm oil, it can reduce the cardiovascular deaths from MI and stroke by 1.3% absolute reduction. When I say 1.3% absolute reduction, it contributes around 20% in terms of relative reduction. So we can reduce something like 20% of cardiovascular disease from MI and stroke by simply increasing the tax on palm oil. Moderate reduction in salt could avert 400,000 events and 81,000 deaths in India alone. Tobacco taxation and smoke-free legislation has the capacity to reduce the myocardial infarction and stroke events in India by 25%. So these simple policy measures, if we can adopt at the national level, it has huge impact at the population level. In terms of cost-effective multi-drug therapy, these days we have poly pills that are available, multi-drugs in single combinations. So incremental cost-effectiveness ratio per dollar per quality-adjusted life years of a multi-drug regimen for secondary prevention of cardiovascular disease conditions would be somewhere around $306 and $746 in South Asians respectively. So what does it mean that now, as we compare it with the GNI per capita of India, at the moment it is around $4,000. So compared to that, it is a minuscule amount. So we can actually spend that much to save that many lives. So, but the problem is that knowing is not enough. We must apply. Willing is not enough. We must do. We need to get some novel examples, novel approaches to address this burden of cardiovascular disease condition. We did a study way back in 2009 across several 10 work sites in India, and I'm showing the results from that worksite project. In that worksite project, there were intervention sites and there were control sites. In the intervention sites, we provided specific interventions targeting the behavior of employees in these work sites. In addition to that, we provided coordination for primary care for managing their blood pressure, managing their dyslipidemia, and managing their diabetes levels. What I'm showing here is that in the intervention sides, all these risk factors, there were significant reduction in all these risk factors, whereas in the control sides, it has actually gone up. So the secular trend is rising cardiovascular risk factors at the population level, but we showed that they are amenable to interventions. For the first time in the Indian settings, we showed that these risk factors are amenable to interventions. One of my PhD students who is doing PhD from UK at the moment showed that task shifting interventions are very important. Task shifting interventions of engaging community health workers in terms of managing blood pressure are highly effective in reducing blood pressure at the population level. And he published his work recently in the Lancet Global Health Journal. And another PhD student of mine, she's working at the moment in Birmingham University, she showed that task sharing strategies are important for diabetes control as well. Whether it is in terms of reducing the HbA1c level, the glycated hemoglobin level at the population level, or the fasting blood sugar levels at the population level, it has significant impact of engaging non-physician healthcare workers. But when I say non-physician healthcare workers in terms of diabetes control, this is slightly different from the blood pressure control because all the workers are not equally effective in reducing. Nurses are effective in reducing, pharmacists are effective in reducing. In a country like India, where there is dearth of physicians, when we compare the physician to population ratio from India to a high-income country, there is huge difference. There is a huge gap where we could potentially use the non-physician healthcare workers in terms of managing diabetes and hypertension at the population level. We also showed that home health interventions are useful in addressing cardiovascular disease condition. Home health interventions in terms of decision support system or algorithms for management of cardiovascular risk are useful for primary care physicians, are useful for nurses in managing cardiovascular disease condition at our primary care settings or even at the population level. We have been able to develop smartphone with decision support system where the nurses could feed in the essential information to a tablet computer and also take measurements using a tablet computer. And with some additional measurements from the participants, the support system would give you the recommendation for appropriate treatment. We showed that the technology-enabled community health worker extending telemedicine to rural homes are effective in managing hypertension and diabetes. This work we did in the rural areas of Telangana, where we could achieve control rates of up to 50% for hypertension and 43% of diabetes. When we compare it to the population level control of 10% or 15%, it is much higher. So engaging these non-physician healthcare workers with technology, with the availability of decision support system, it is useful to control blood pressure and blood sugar at the population level. We did a massive study across India, which is called the Disha study, of engaging non-physician healthcare workers in managing hypertension. The study is at the moment ongoing, but the initial results are encouraging. There are altogether, there are 60 clusters in the intervention unit and 60 clusters. When I say clusters, they are villages. So 60 villages in the intervention unit and 60 villages in the control unit. And we are expecting that we would be able to demonstrate reduction in blood pressure at the population level, which would have serious implications in terms of designing our policies for control of cardiovascular disease in the Indian settings. We did a study in Trivandrum, Kerala, which is called the Kerala Diabetes Prevention Project, where we engaged the community through in terms of prevention of diabetes by peer education programs. And we demonstrate that through peer education program, we could reduce the risk of developing future diabetes in high-risk population. And we were able to also scale it up to the different regions of Kerala with support from the World Diabetes Federation. And we were able to educate over 5,000 peer educators, and they were able to further educate over 100,000 participants in terms of reducing the diabetes risk at the population level. We conducted a study called the polypill study, which is called the umpire trial, where we showed that instead of giving drugs as separate units by combining them into a single unit as a single pill, if you offer it to people after their heart attack or stroke, which could potentially increase their adherence to these drugs level. Remember that slide that I have shown after the heart attack or stroke, up to 80%, 50 to 80% of these people are not receiving even a single drug. And that is the adherence related issue. So that could be addressed by providing a polypill. We also showed that by engaging family, by engaging family in cardiovascular risk reduction, we could potentially reduce cardiovascular risk. We worked with families of individuals with premature coronary artery disease, those who develop coronary artery disease before the age of 55 years. We selected those families and we randomly assigned them into two groups. One group received the interventions, which include lifestyle interventions coordinated by a non-physician healthcare worker. In addition to that, management for cardiovascular risk factors through our primary healthcare system, which are already established in the Kerala setting. And at the end of it, we could show that there is relative benefit in terms of reducing the cardiovascular risk. So what did we show? That there is cumulative decline in the intervention group in terms of cardiovascular risk. So if you see here, the Framingham risk score, the mean Framingham risk score, which reflects the total cardiovascular risk at the individual level, in the intervention group, it dropped down from 12% to 8%. That is about 4% absolute reduction. And whereas in the control group, it remains at the same level. So 4% absolute reduction at the population level, even in the Kerala settings, could avoid 50,000 events in Kerala annually. 50,000 events, cardiovascular events like heart attacks and strokes could be averted by this intervention. So we know that these interventions work, which could potentially improve the optimal blood pressure levels, optimal blood cholesterol levels as well. So the global monitoring framework developed by the UN to address the non-communicable disease burden by 2025 include certain indicators or the framework, the monitoring framework, which include diabetes. The target is to diabetes, obesity, 0% increase by 2025. Raised blood pressure reduction of 25%, tobacco reduction of 30%, salt or sodium consumption of 30% reduction, physical inactivity reduction by 10%. By addressing only these 6 risk factors, we could save 16.1 million deaths, or either delayed or prevented at the global level. So these are potential interventions. So how can the countries respond to the burden of cardiovascular disease? Definitely, as I said, we need to think about the regulatory innovations in terms of the policy interventions. We need to think about workforce innovations in terms of enabling and empowering our health workers to manage cardiovascular disease conditions, which include not only doctors, but also community health workers as well. We need to think about the digital patient-centered technologies, like the telemedicine technologies or the decision support system. But we need to be mindful of the fact that while we design the digital patient-centered technologies, we are not increasing the equity divide, because it should be accessible to everyone. If it is only accessible to the digitally savvy people, then that is not appropriate. We need to develop public health intelligence system where we need support from the engineers to design appropriate intelligence architecture where our information is safe. We need to also think about providing universal health coverage where we could cover all essential drugs for managing cardiovascular disease conditions. This requires innovation in policy, innovation in health service delivery, how we manage these conditions, also innovation in behavioral economics, how we can influence the behavior of individuals, which could cumulatively drive the change and which could cumulatively reduce the population burden of cardiovascular disease conditions. And finally, I quote Toni Morrison from her novel Song of Solomon. If we don't create the future, the present extends itself. And we cannot afford to do that. If the present extends, many more lives will be lost from cardiovascular disease conditions. And thank you for listening to me.
Thank you, Dr. Jimon, for this very, very impressive talk. In fact, it's one of the most impactful lectures that we had in the series of a distinguished lecture IEEE MBS Kerala Chapter. In fact, you have given very good perspectives about the Indian and world scenario, especially related to hypertension, diabetes, as well as cardiovascular diseases. So, very interesting to see the social gradient as well as health transitions. More importantly, the influence of tobacco, cholesterol, BP, and other causative factors. But I was really happy to hear that the transition from public health to sustainable growth as well as social inclusivity were part of your research. As well as a comprehensive response to CVD related activities. So, in fact, it's of particular interest that the price of action as well as inaction that you had mentioned, the particular significant cost of inaction. It is very, very interesting. So, of course, we were also briefly discussed about the policy changes through various aspects, including cost-effective multi-drug therapy, task shifting, task sharing, and M-Health as well as technology-enabled treatment policies like digital patient or telemedicine and so on. It is very, very impressive and impactful to see that these studies and research actually make a very big impact in the society. We have time for a few questions from the audience. If there is any questions from the audience, we can take it now. You can turn on your mic and ask, or even you can use chat box. Either way is fine. Any questions from the audience? Yeah, I think Srikar has a question. Srikar, you can turn on your mic and ask, or you can write that into the chat box too. Yeah, Srikar, you can just type in the question, or you can ask. Yeah, Srikar is asking, can you please elaborate on how tech could help in this field of medicine?
Oh, I think technology has a lot of importance, especially the digital technology. First of all, in terms of building a system for surveillance. Remember, when we talk about health data, we are talking about personal data. We don't have a robust system to keep to ensure the privacy of the data that we collect, and that is one of the reasons why many people are not willing to share their health data. And the important thing is that interoperability for these systems. Now, we have systems in place for our private providers, especially in the high corporate settings where they collect a lot of information. But there isn't any interoperability across this system. In our public health system, where we have primary health centers, community health centers, taluk level hospitals, district hospitals, and medical colleges, there is no linkage between them. So that, if the patient comes to a primary health center and then it's been referred to higher center, and after appropriate treatment from the higher center, if he referred back to the primary health center, there is no way we can link that person and see whether they are taking the appropriate essential medicine. So there is definitely an important need to develop systems, especially robust architecture, so that there is we can link them appropriately. And these days, one of the most important issues that we are facing is that earlier we were facing was lack of an unique ID. Because now we have that problem has been solved with our Aadhaar ID. But people are not willing to share the Aadhaar ID only because of the fact that they are worried about their privacy related information. But can you ensure a system where you can offer a robust system where the confidentiality is ensured, that at a reasonable level, so that we can gain the confidence of the people. In addition to that, in terms of managing disease conditions, we need to develop systems which we call it as decision algorithms. So it is very difficult for us to train the large number of primary care physicians based on our latest guidelines for managing various disease conditions. Think about a primary care physician who is working in a primary care settings. He would be treating n number of disease conditions. The latest updated guidelines may not be familiar to him. He may not have even saw those guidelines because he may not have read those new articles or the new journal publications. So how can we get that guidelines to them? We can get it through a decision algorithm. So whereas when he feed in some information, the decision algorithm will provide or indicate appropriate strategies for management. So we can invest in such system. We can invest in the telemedicine to reduce the gap between offering services to the people who are really required, especially in the difficult rural regions, especially in the tribal setting. I'm not saying that we don't have this system. We have this system, but these systems are not at the moment, not at the optimal level. We need to invest more and see that it is easy to use. It can connect with multiple layers of people. It is useful for patients, and also importantly, it does not increase the health gap between those who can access the treatment and those who cannot access the treatment. The reason why I'm saying is that if it is only accessible to people who have access to internet or who have access to a smartphone, then that is difficult, because in our country there's a large number of people do not have access to this kind of sophisticated devices. So if we can develop or if we can come up with new solutions to address this one, technology will have definitely an important issue. One of the things recently that we were working with NIIT Calicut was developing a simple algorithm for managing anticoagulation therapy for people after a valve surgery, or those who are with a condition called atrial fibrillation. They will be on lifelong warfarin treatment, and they need to check their coagulation levels in the blood. So normally they go to a lab and get their PT-INR levels monitored on a monthly basis. And after that, they need to go to a cardiologist and see it. And the cardiologist will adjust the dose of the anticoagulation therapy. We can easily bypass that. If we can develop an algorithm saying that, okay, these parameters, based on these parameters, based on this PT-INR value, this is the adjustment that is required. We don't need the intervention of a cardiologist there. Probably the intervention of cardiologist is there to look at some extreme values, but within the common range, it would be easily manageable. So those kind of decision algorithms we can easily develop and build in, which could be really useful for improving the delivery of primary care in our primary care settings.
Yeah, good, thank you. And in fact, Trigger had one more related question, that is, what in your opinion would be helpful in future for the amalgamation of technology and medicine?
Well, I think technology is an important thing. It's going to remain there for the next several decades. Innovations in technology. Things are drastically changing in the Western world, at least, because if you actually look at how people reading radiographs, how people read pathological report, it's completely changing because it's all based on artificial intelligence these days. So we can also come up with similar models, because those models will not work in Indian settings. We cannot simply replicate those models because our profile is totally different. Our patient population are totally different. The parameters are also totally different. But we could develop our own system to enable the doctors to diagnose disease conditions appropriately, enable the doctors or physicians to treat the disease conditions appropriately. Not only treating, monitoring the progress in terms of their progression to an advanced state, or in terms of regression back to the normal situation. And then if we can offer customized treatment or personalized treatment, it would be really good. Now we are into the era of personalized treatment. Now with the advancement in genetics, advancement in proteomics, advancement in metabolomics, we can get a lot of markers. If we can integrate all those markers with their pharmacogenetics or pharmacokinetics, as well. So we could offer definitely personalized medicine to the individuals based on their risk factor profile. So they are all important, though those requires technological advancement. So those require support from, definitely supports from engineers and software professionals.
Thank you, Jiman. And one more question from my side. I have so you have mentioned the policy changes for enhancing the CVD prevention. So have you ever attempted requesting the government to consider these policy changes that you suggested? Because most of the times, the research goes in one way, the implementation of that by the government agencies will not be aware of the research that is happening. So, in fact, even research paper will not even be read and understood by the administrators or policymakers too. So, have you had any attempt at trying to communicate with the government agencies in implementing some of the policy changes?
Yes, I think that's a very important question. I think the response to that question is that no, I think there is a classic quote. The policy making is as equivalent to sausage making, and if you get to know how the sausages are made, you never eat those sausages. Similarly, the policy making is also like that. Now, I mean, it is not really based on the evidence that's been provided or evidence that's been generated. There are multiple reasons why certain policies are adopted at certain point in time. Because politicians always look at in a different angle, and they are only interested probably in the short-term gains rather than long-term investments. But when it comes to policies related to cardiovascular disease conditions and non-communicable disease conditions, we were able to influence policy, at least in terms of increasing the taxation of tobacco, increasing the taxation of alcohol. Even in Kerala, the previous the finance minister could introduce the fat tax. Although it didn't work really well, but these are some of the strategies that has been, we could potentially influence people and say that, okay, these are some of the adverse impacts. Therefore, we need to address this situation in our society. And sometimes people, sometimes politicians supports us as well. In terms of universal health coverage, at the moment we were strongly arguing for including all the cardiovascular medicines as part of the essential medicine list. And we were able to get that approval from Government of India. Now all the essential medicine, all the cardiovascular medicines are part of the essential medicine list of India. WHO has a separate list which has some additional medicines as well. We are still pursuing that with the government to get all those important drugs as part of the essential medicine. So it is possible to influence policies. But it's not a straightforward as easy process. It requires multi-level engagements, not only from the researchers. The demand from the population needs to be articulated through other civil society members as well. So we need to engage the civil society in that process. Otherwise, it's not going to happen.
Thank you, Dr. Jimon. And there is one another question from Dr. Seena V, who is an associate professor with the Institute for Space Science and Technology. And the question is, with regards to lifestyle changes, would you like to know about the studies on yoga for preventing? I think the question was, yoga for preventing or managing cardiovascular disease.
There are limited number of studies that are available at the moment in terms of preventing cardiovascular disease conditions. But the one study that is a randomized controlled trial that's been done in the Indian settings, this is after an event like a heart attack event. They encourage the participants to get involved in yoga. It's not completely yoga related physical activities that could reduce the mortality after the event of acute myocardial infarction. But I think the specific question is related to prevention of cardiovascular disease conditions. But I don't see that there is, definitely it will have an impact. Even if in epidemiology, we say that absence of evidence is not evidence of absence. Just because of the fact that the evidence is not available, it doesn't mean that it's not existing. So since people are not doing appropriate studies, the right rigorous randomized control trial to evaluate yoga, that doesn't mean that it may or may not work. So I think it has all the ingredients in it. It has all the lifestyle processes or lifestyle changes inbuilt in the yogic the yoga curriculum. So it should definitely have an impact. But I mean, I'm not. I mean, I'm not at least familiar with any rigorous designs where they evaluated prevention of cardiovascular disease condition using yoga.
Thank you, Dr. Jimon. Sushant Suresh has a question on with an increasing demand for technology in the biomedical sector, what can be the potential steps to enhance the collaboration between medical and engineering universities?
See, I think the crosstalk is not happening. I think you work in silos, we work in silos, the clinicians work in silos. The crosstalk is not happening. I'm very happy that you invited me to talk to engineers and mostly engineers. And I think those kind of crosstalks would be helpful. And it would be interesting for me to know what you are doing. What is what kind of capacity, what kind of skills that you have. And after that, we would be able to solutions to the existing problems. So that unless and until that crosstalk happening, it is very difficult to come up with novel solutions. I think we need to, at the institutional level, we need to encourage that across any disciplines, whether it is, I mean, avionics, whether it is medicines, whether it is some other fields. I think we need to encourage that crosstalks. And only if that happens, we would be able to come up with very, really useful solutions for the society.
We will do that. At the IEEE EMBS Kerala, we are determined to do that kind of collaborative events where such kind of activities across the domains can happen. So Sridhar has one another question. Is it possible to stop being paranoid about over dependence on technologies, taking into account the recent trends in spread diseases?
Well, I think I didn't understand that question completely, but definitely, if I understand it correctly, definitely it is not only technology. Technology is an aid that supports that process. I'm not saying that technology will completely resolve all our problems. We need to have that patient-physician interactions because the patients trust the doctors. And also in terms of prevention of disease conditions as well, technology may not have all the options available. So technology could be only used as a tool, as an aid to address this problem. So over dependence on the technology also a problem. That is what I mean. That is one of the issues that the high-income countries are facing at the moment.
Okay, thank you, Dr. Jimon. I would like to share a virtual memento to you so that as a mark of our appreciation, we would like to extend. We'd like to request you to accept this virtual memento. Are you able to see the virtual memento? 1 second.
Something is coming up, sir.
Yeah. It may take a while. There is a little bit of bandwidth problem. Looks like, yeah. Maybe you will be able to see this virtual memento.
Yeah, thank you, sir. Thank you very much.
Yeah, thank you. So now I would like to request Vinod Kumar to extend a vote of thanks to Dr. Jimon and others assembled here.
Dr. Manoj, am I audible?
Yes, please.
Yeah, a very good evening to all of you. As the treasurer of EMBS Kerala chapter, it's my responsibility to propose a vote of thanks in this meeting. First of all, let me thank Dr. Jimon for the eye-opening talk on cardiovascular diseases, especially for mentioning how technology can solve the issues in controlling cardiovascular diseases. On behalf of IEEE EMBS and on my own behalf, let me extend my heartfelt gratitude to you, sir. Then Dr. Manoj, our chair of IEEE EMBS Kerala chapter, he is actually running around a lot for organizing series of talks like this. On behalf of other IEEE EMBS members, let me thank you, sir. And our senior members and life members of IEEE and IEEE EMBS who are joined this meeting virtually. We thank each and every one of you. Then the members of IEEE and IEEE MBS and the student members, we thank each and every one of you for joining us and making this talk, the distinguished lecture series a success. Thank you all very much.
Thank you, Dr. Jimon. Thank you, Dr. Vinod Kumar, and all others here. Thanks again.
Thank you very much.
Any other questions you can take offline with Dr. Jimon. Thank you.
Thank you.